Good evening, everyone. Thank you very much for joining us this evening. My name's Rachel. I'm one of the specialist nurses here at Pancreatic Cancer UK. This evening's webinar is focusing on treatment for pancreatic cancer. You can't have surgery. And it's going to be hosted by my nurse colleague, Lynne, and myself. So before we get started, there's just a few quick bits of housekeeping to run through. And I'll also share some information about the support we can provide for you and your family at Pancreatic Cancer UK. There will be a Q&A session at the end of the webinar. You should see a Q&A icon on your screen, which looks like two speech bubbles. And to ask a question, just type it into this box. Feel free to ask questions throughout the session. There's no need to wait until the end. Please do be aware that any questions you ask will be visible to all attendees. You can choose to ask a question anonymously if you prefer, and you can upvote questions by clicking on the thumbs up button, which will then boost them to the top of the list. There might be questions that you have that are highly specific or fall outside of the scope of today's webinar. So that we can keep the questions we answer relevant to as many people as possible, we may, in these cases, reply in the Q&A box, offering signposts to support and information, or perhaps encouraging you to call our support line rather than reading your question aloud. So we hope you understand that. Please remember to type your questions into the Q&A box and not the chat box, as they might get missed there. If you're joining from outside the UK, you're really welcome, but just please keep in mind that the information we give will be based on the UK health system, and we won't be able to advise on options elsewhere. The webinar is being recorded and will be made available on our website afterwards if you'd like to watch it or share it with other people who might be interested. So I just wanted to talk to you briefly before we begin today about the services that we offer here at the charity for people affected by pancreatic cancer. I'm aware that many of you will already be familiar with perhaps a couple, if not all, of these services, but for those of you that aren't, this is just a quick reminder or a quick introduction. The support line is run by myself and 6 other friendly nurses with a wealth of pancreatic cancer experience. You can contact us about anything, managing symptoms, questions about your diagnosis, treatment options, or just to talk about how you're really feeling. Your family members can call us too, as can health professionals. You can see the telephone number on the slide now, along with our email address and opening hours. We would really love to hear from you. We have a wide range of information available. We have short videos about pancreatic cancer and what having chemotherapy and surgery might entail. Lots of information on our website about treatment, managing side effects such as fatigue, taste changes, and also fact sheets, some of which we'll be highlighting this evening, and booklets covering all these topics and more. The publications are free to order. Post those out, or you can download things to be read at home. You can find this from the information link on the slide or from our website under the Support for You tab. We also host online support sessions on a regular basis, covering a wide variety of relevant topics. You can find all the information you need on our website. It's easy to book on, and if you do need any support in using Zoom, join the sessions and we can talk you through that. Sessions are really relaxed and informal, and as well as being able to ask any questions you might have, it's also a really good opportunity to meet other people who've been diagnosed or are supporting someone with a pancreatic cancer diagnosis. And then finally, we have our discussion forum. The forum is accessible 24/7 and there is a supportive community online. You can access the forum again via our website. The link's there on the screen, and it's really simple and straightforward to register. We just ask that you read through our forum guidelines before you post. Okay, so we're now moving into the main bit of this evening's webinar, exploring treatment for pancreatic cancer if you can't have surgery. This evening we are considering what active anti-cancer treatment options there are available for people that have been given a diagnosis of pancreatic cancer but are unable to have surgery. We're going to cover an introduction to treating pancreatic cancer, chemotherapy, radiotherapy, irreversible electroporation, and also clinical trials. As we begin, it's important for Lynne and myself to highlight that we will be covering a general overview of these treatments and offering general thoughts around them that we hope will be helpful for you. We won't be able to be prescriptive and aren't able to discuss individual cases. As I've already mentioned, we are very happy to chat to you more specifically about your individual situation via our support line. So we're going to start with an introduction to treating pancreatic cancer. And back in 2018, an organisation called the National Institute for Health and Care Excellence, or NICE, published the first ever guidelines on diagnosing and caring for people with pancreatic cancer. The idea behind this was to set best care standards to reduce variations and transform care for people with the disease. It aims to improve care for people with pancreatic cancer by ensuring quicker and more accurate diagnosis and by detailing the most effective treatments for people depending on their stage of disease. The NICE guidelines cover England, Wales, and Northern Ireland and are based on the best evidence available. There are also guidelines for cancer care across the UK. It highlights that people have a right to be involved in discussions and make informed decisions about their care. And we have a fact sheet that you can see a picture of there on the screen that helps to explain these guidelines in a bit more detail if you did want to have a look at that. So after you were diagnosed with pancreatic cancer, you may have been told surgery to remove the cancer is not possible. However, you may be able to undergo other treatments for your pancreatic cancer. In order to get to the point of having treatment, you will undergo lots of tests, have numerous hospital appointments, and there will be many considerations from your own perspective and the healthcare team looking after you. And all of these things together influence and impact anti-cancer treatment, if it's appropriate and safe, or which particular treatment is best. So on this jigsaw puzzle on the screen, I've written down many things that this includes, and I'm sure there will be actually more that you could add. So I'm just going to go through these. So your wishes. It's hugely important to think through your wishes as a patient and as a loved one of someone diagnosed. You may be very clear from the outset that you don't wish to undergo any active anti-cancer treatment. Others of you may be unsure and wish to find out more about what the options are, and what the possible side effects of these treatment options might be in order to make your decision. And it's important that as patients and family members, you have access to good information, allowing you to make informed decisions. Imaging. So you may have been diagnosed with pancreatic cancer following imaging, for instance, CT scan. And after your initial scan, you may need to have further imaging to gather more information about your pancreatic cancer. And this is often referred to as staging. Conclusive biopsy result. In order to undergo treatment, you will need to have undergone either brushings of the bile duct, which is often done during a procedure called an ERCP when a bile duct stent is inserted, or a biopsy. This is when a sample of the pancreatic tumour is taken. And the results of these must give a clear or conclusive answer that shows the type of pancreatic cancer you have. This is sometimes called a tissue diagnosis or a histological diagnosis. If you're very clear from the outset that you do not wish to have anti-cancer treatment, then this is not needed. After a conclusive tissue result has been achieved, a multidisciplinary team, or MDT, will usually discuss together what they feel is the best treatment option for you. And if appropriate, usually you would see an oncologist. This is a doctor that offers treatment such as chemotherapy. At an oncology appointment, there will be assessment of fitness in order to make sure you're well enough for treatment and that it will not be more harmful than helpful. And I'll say more about this in a minute or two. It could be that you are struggling with symptoms such as pain or loss of appetite and have lost lots of weight. And you may need help in managing these symptoms before any treatment is considered. Your past medical history would be taken into account, as will the results of your blood tests. And all of this is to ensure that any treatment that is given is as safe as possible and is in your best interests. Benefit. As I mentioned above, it's really important to think through your wishes, and within this, thinking through the possible benefits of treatment. This might be improved symptom control or extending life, and this needs to be balanced with thinking about the possible burdens of treatment. For example, side effects of treatment such as nausea and diarrhea and time spent in hospital. And these things are likely to impact day-to-day quality of life. So it's really important to carefully consider what your expectations are. It's important for you to know as much as possible about the treatment in order for you to give informed consent, and there should be joint decision making. So I mentioned just earlier about assessing fitness, and this table uses the Eastern Cooperative Oncology Group, or ECOG, scale to assess something called performance status. This describes someone's level of functioning in terms of their ability to care for themselves, daily activity and physical ability, such as walking, working, etc. In medicine, performance status is an attempt to quantify a person's general well-being and activities of daily life. And this measure is then used to determine whether you can receive chemotherapy, and it can also help give guidance on dose of treatment. A good suggestion is think about what questions to ask before going to see an oncologist or perhaps another member of your healthcare team. And you can write these down beforehand and take them to the appointment with you. We also suggest that it can be really helpful having someone with you, as 2 pairs of ears are better than one. And it can definitely be hard taking in a lot of information in a short space of time. And the second person can perhaps make sure you ask all the questions you would like to. So there's just some examples of questions there that you might like to ask on the screen. So I'm now going to introduce my nurse colleague Lynne, who's going to then take us into the next part of the webinar.
Hi there, I'm just going to share my screen. Hoping everyone can see that. So thanks for the introduction, Rachel. I'm going to take a few minutes now talking about pancreatic cancer and the treatment chemotherapy. So what will I discuss tonight? So we're going to have a chat about what chemotherapy is. We're going to explore how chemotherapy is used to treat pancreatic cancer and how this has changed over time and what influences that. And we'll discuss how to keep well on treatment and in between treatments. So chemotherapy. I always like to start with the basics when talking about any treatment. And so understanding that chemotherapy is actually one word that describes lots of different drugs. And within cancer, we use these in many different ways. Chemotherapy is something we call a systemic treatment. And what that means is that it's something that is given intravenously or taken orally or given in a way that means that it travels around your system. It isn't like radiotherapy, which is a localized treatment. I often describe chemotherapy as the systemic part of it is like giving weed killer to the entire lawn. Radiotherapy is like pulling out individual weeds. And it's something that we call cytotoxic, which means cell killing. So how does chemotherapy work? Well, you probably know all this, but we're just going to take you back to biology at school. But all our bodies are made of billions of cells. And once we're fully grown, these cells tend to not really divide too often only dividing, replicating when we need to repair damaged cells. There are some cells in our bodies that are constantly changing themselves, and we'll come to that in a moment. In the center of each living cell is the nucleus, and that's the control center of the cell. So it contains the chromosomes, which are made up of genes. And as the cell begins to divide, the information that is in the nucleus will be split, and will be identical in the two new cells that have been produced. So in cancer, an abnormal cell will keep dividing until there is a mass, and those abnormal cells and mass become a tumour. Chemotherapy, the aim of chemotherapy is to damage the genes inside the nucleus of the cell. And so that when the cell divides, the cancer cells divide, so much more often than normal cells. And this is why chemo is really good and more likely to kill them. Often we use combinations of chemo drugs for different types of cancers because different drugs have different effects on that cell division. The chemotherapy that we use in pancreatic cancer, we give in different settings. So I thought it was useful to explore those terminologies. So chemotherapy can be used neoadjuvantly, and this means that it's given before surgery to try and shrink the cancer, and that gives us a better chance of removing it. It also can be given adjuvantly, and that's after surgery, and that reduces the risk or the chance of the cancer coming back. It can be given for those people who have locally advanced disease, and that's to help control the growth of the cancer, extend life and maintain quality of life. And it can also be given in the palliative setting. So this again is given to control the growth of the cancer, maintain quality of life and to extend life. You may have heard of some of these drugs. Some of you here tonight may be on some of these drugs, but I wanted to just discuss the common drugs we use in pancreatic cancer. Gemcitabine, capecitabine, 5-FU-irinotecan and oxaliplatin. They all sound like big complicated words. You'll see next to them we often abbreviate them. We often use the drugs that are in this list in combination. Just as we have said in the previous slide, we often use chemotherapy drugs in combination to have the maximum cell kill in pancreatic cancer. So how do we know which drugs work for who? So we'll talk about clinical trials a little later on tonight, but I wanted to include it here because how we know what works is all a result of clinical trials. Clinical trials give us the best evidence for what treatment we might be able to use in standard care. So over the history of time, different drugs are used in different combinations to see whether they're helpful in treating pancreatic cancer. So after surgery, we first thought, well, one drug, that seems to have a good effect. A little further on in history, a few years later, we think, well, one drug's great. I wonder if two drugs are better. And then a little further on in our understanding and drug development, it's two drugs are better than one drug. But I wonder if three drugs are better at treating people after surgery to prevent the cancer coming back. And we talked about neoadjuvant, so before surgery. This is an emerging field of treatment, but researchers showed us that actually giving people some chemotherapy prior to surgery, or for borderline resectable people, actually increases the likelihood of them going for surgery. This is something that is expanding within the research field. So this is an interesting part of research going forward. In regards to palliative treatment, so this is the treatment that we give that we hope to control the cancer, to maintain quality of life, and also extend life. You will see from the arrows that are going across your screen, we started exploring these types of treatments way back in 1997. There's been a lot of clinical trials in this field, and these are the key ones that have influenced practice in the UK. And so how do we decide what drugs we use first? You might have heard things in clinic that they talk about first line treatment and second line treatment. And often the things that influence what we use first line, as Rachel has already discussed, is fitness, choice, comorbidities, symptoms, etc. But thinking just of the research, what we know is that FOLFIRINOX, which you may have heard of, which is the 3 drugs, the evidence indicates that that is the best in regards to outcomes. So it's the best at doing what we want it to do, and is often used in first line treatment. Is chemotherapy right for everyone? Rachel's touched on this already, so I'll briefly go over it. It certainly is something that we have to weigh up the benefits and burdens of. And so what do we know? So we know if you're having chemo after surgery, it can stop the cancer coming back. Chemotherapy can control the cancer, shrink the cancer, extend life. But it can come with burdens. As already discussed, those burdens can be, we don't know who will benefit from chemotherapy and who won't. There's often side effects. You often have to go to a hospital more because you're having routine bloods and checkups and scans. So these are the things that we have to weigh up. Well, you have to weigh up when you're thinking about what might be the right decision for you in regards to any treatment, but particularly chemotherapy. And again, Rachel touched on this, but fitness and performance status can influence the options regarding chemotherapy. So that the drugs that we've discussed, we've talked about the drugs, that 1 drug, 2 drug, 3 drugs. The FOLFIRINOX is 3 drugs. We know that this can come with increased toxicities, increased side effects. So we want people to be as fit as they possibly can be when embarking on that. People who maybe are less fit or have increased comorbidities, we might consider the other chemotherapy regimes. So using the doublet one, so the two drugs together, or for some people, we might use gemcitabine on its own. Thinking about how we prepare for chemotherapy, and I wanted to discuss this and keeping well on chemotherapy, because I think this is really important when weighing up your options, and also understanding sometimes when there is those delays to starting treatment. I can understand completely why people want to start treatment as soon as possible, but we have to allow ourselves, or yourself, to recover from the procedures that you may have had before chemotherapy. This could include surgery, insertion of stents, particularly if you're jaundiced. Jaundice needs to be resolved before chemotherapy can start. And this can be frustrating for people, but understanding that can help to really reduce that frustration a little bit. It's also important to think about any other symptoms that you might have and use that time before starting chemotherapy to address those symptoms. And who can help with this? Well, we can help on the support line here at Pancreatic Cancer UK. I would also say it's important to link in with your hospital team, and you may know the clinical nurse specialist there. Some people will be referred for community palliative and supportive care services like McCallum nurse, or from nurses who work in the community from other cancer centres and hospices. These people are key in keeping people as well as possible for as long as possible, and also really proactively managing people's symptoms so they can start treatment, keep well through treatment, and also go on to have further treatment. Diet, exercise, and emotional well-being are all key parts to preparing for chemo and keeping fit and well going forward. Exercise, I would say you don't need to be running marathons or start squat thrusts unless that's what you already do, but certainly some gentle exercise and trying to maintain muscle mass, so gentle weights in a chair would be totally fine. That can be more difficult for different people, and we have to accept that. But gentle exercise is really helpful. Emotional well-being is something that sometimes we can overlook. There's so much else going on, but actually it's really intrinsic for overall well-being. And again, who can help you with that? Well, you know, we are able to signpost on the support line, linking up with your hospital team, your nurse specialist and your GP, should you be, if you've identified that you're struggling a little bit emotionally. Keeping well. So having good information about chemotherapy, having proactive support whilst you're on chemotherapy, I think is really important. And these come in all sorts of guises, which we've already touched on. We have information about chemotherapy, broad information, but we also have specific information on our website regarding each individual treatment. We also have the online support sessions. There is other institutions, other services that you might be able to link in with. Maggie's Centre is a cancer centre that's in various locations across the country. They have fantastic resources, as do McCallum. And it's key to keep in communicating with the team that is providing your care, your oncology nurse specialist, or your your supportive care nurse. Don't wait for things to become big problems. If you have a question, ask. We know that chemotherapy can cause side effects. We know that some chemotherapy, some different side effects are more prominent than others. And some of the key ones that you will be aware of is bone marrow depression. So bone marrow depression means that within your bone marrow there's white cells and red cells. White cells fight infection. Red cells are hemoglobin, which carries oxygen around your body, and platelets, what clots yourself if you are if you cut yourself or bruising. So the white cells are what we are concerned with on chemotherapy. So if your white cells are low, you're at more risk of picking up an infection, which we'd normally brush off. We don't wrap people up in cotton wool. We want people to have as normal life as possible, but we also want you to be aware of your of your risk. Good hand hygiene is key. Please buy a digital thermometer, keep in touch with your team, and I'll touch on the support line the chemotherapy hotline in just a sec. Other common side effects that you may be aware of that might need some advice is nausea and vomiting, diarrhea, sore mouth, hair loss, rash, sore hands and feet. Proactive side effect management is key. But what does that really mean? So we've touched on this already. Keep talking to your team. If you've got side effects or symptoms that you're not sure how to manage, get in touch with your team. It might be that you call the chemotherapy hotline. Keep a diary about how you feel. It doesn't need to be war and peace. Just little notes after each chemotherapy can help build up a pattern, and that can help you and your team discuss which days you may need more support on, or what symptoms or side effects are causing you the most trouble. If you have a side effect, treat it straight away. Some people, you don't wait till it gets bad enough to call someone. Dealing with things straight away prevents things becoming a problem. And make sure you know who to call if you have an issue or something you wish to discuss. If you have any urgent side effects, or you have a raised temperature and you're not sure what to do, you must call your chemotherapy hotline straight away. Day or night, they're open 365 days of the year. Sometimes when on chemotherapy, we need to have treatment breaks, and sometimes chemo dose reductions, and these can feel quite significant for people. Sometimes people can feel that is a failing, and it isn't. These are really, really normal things that we do, and a very, very good way of managing side effects and keeping you well. Sometimes people feel that they can't discuss their side effects and toxicities and how they feel with their team for the risk of treatment stopping. But I would say having those discussions ensures that you keep well and that treatment continues. So what happens when chemotherapy finishes? You will have a scan called the end of treatment scan. You'll be seen by your oncologist. You will then be placed on something called active surveillance. And what that means is that you will have scans every 12 weeks, but you will also be able to call nurse specialists, the team, if you are concerned about any symptom, or if you have anything new that you need to discuss, and they'll be able to see you earlier, and they may be able to get the scan earlier. But this period of active surveillance is really important, because what that allows you to do is enjoy some new normal for you life in between treatments. And so those scans are done every 12 weeks. In those 12 weeks, we'd expect you to feel better, to recover from that dose of chemo. Some people will say, why can't we have chemo continually? That impact on your bone marrow and side effects and fatigue is something we need to allow people to recover. And the best way to do that is have a stint of chemotherapy, some active surveillance, and then follow up with scans. And what might happen next is that imaging will be done, and should changes be ever seen, or should there need to be, we'll discuss at that point further treatment, and that could include standard treatment, it could include clinical trials, and that will be an ongoing discussion with your team. So again, it's circling back to how very important it is that you know who it is to call if you have any questions in your team, or if you want to know what is happening next. So some take-home messages, very briefly. Chemotherapy, we know, is helpful after surgery and when surgery is not possible. Standard treatments are based on evidence from previous clinical trials, and there's been some recent promising studies at having chemotherapy before surgery. What treatment is suitable for each person is decided on many, many different things, but keeping well on chemotherapy is a priority. Diet, exercise, emotional well-being are really key to this. And so knowing where you can access support is really important. Getting the support you need when you need it is really, really important on chemotherapy. And that comes in many, many different guises. So I'll hand back over to Rachel. I'll just stop sharing my screen. Sorry.
All right, thanks, Lynn. Okay. Just going to share my screen again. All right. Ticks. Sorry, I'm just gonna having a bit of a problem there. 2 ticks. Sorry. Okay. So Yeah, thanks, Lynn. So our next section is looking at the treatments of radiotherapy and irreversible electroporation, which is a bit of a mouthful. So that's abbreviated to IRE, or some people might know it as nanoknife. So, firstly, we're going to look at conventional radiotherapy. So radiotherapy uses radiation to destroy cancer cells. A machine directs beams of radiation at the cancer from outside the body. It's usually a machine called a linear accelerator, or LINAC, which is used to deliver radiotherapy for pancreatic cancer. As Lynne has mentioned, radiotherapy is a localized or targeted treatment, so it's different to chemotherapy, which is a systemic treatment which works right around the body. We would usually see radiotherapy being given to people that have borderline operable pancreatic cancer to try and shrink the cancer enough to make it possible to remove it with surgery. And it's also given to people that have locally advanced pancreatic cancer to try and help control the cancer and slow down its growth. Usually radiotherapy is given with chemotherapy, and this combination is called chemoradiotherapy. And the chemotherapy drug that is most often used with radiotherapy is a drug called capecitabine, and this is a tablet that can be taken at home. Some radiotherapy may be used on its own, but this is less common. A CT scan is usually done 12 weeks after chemoradiotherapy to assess the impact of the treatment on the cancer. The reason why there is a delay in doing a scan is because radiotherapy continues to work after treatment has finished, and also radiotherapy can cause inflammation. So that can mean that interpretation or reading of a scan, a CT scan, can be difficult. So therefore it's important that there's time given to allow for any inflammation to settle down. If someone has pancreatic cancer that has spread to other parts of the body, sometimes called advanced or metastatic pancreatic cancer, it may cause pain by pressing on organs or nerves near the pancreas, and radiotherapy may help with this pain. This is called palliative radiotherapy, and palliative radiotherapy may also be helpful if the cancer has spread to other areas such as the bones. Sometimes there are clinical trials, which Lynne's going to come on to in a little while, that are available that involve radiotherapy or chemoradiotherapy that you can be part of. Radiotherapy for pancreatic cancer is usually what we call image-guided radiotherapy, and this means that scans or x-rays are taken during radiotherapy to check that you are in exactly the right position during treatment. The different types of radiotherapy all aim to focus the radiation on the cancer and limit the amount of radiation to surrounding organs and healthy tissues. There are different types of radiotherapy used in pancreatic cancer in the UK. So each radiotherapy treatment session is called a fraction, and usually it's given every day, Monday to Friday. Most treatment courses last from around 3 to 6 weeks, but this will vary with the type of radiotherapy given and also the hospital that's giving the treatment. If it is palliative radiotherapy, usually fewer treatments are given and the dose might be lower as well, which can reduce the risk of side effects, although there may still be some short-term side effects depending on the area that's being treated. Before radiotherapy starts, there will normally be a planning session, and this is to work out how much radiation is needed and the exact position you would need to be in on the radiotherapy table. The planning session can take up to 2 hours, and you would usually have a CT scan, and the radiographers will make tiny dots or tattoos on the skin around the area being treated. And they will then use the scan and the tattoos to help get exactly the right position for each treatment session. The whole process would usually take about 30 minutes, but the treatment itself only actually takes a few minutes, and you can go home as soon as each treatment is finished. And after radiotherapy, it's safe to be around other people, including pregnant women and children. Radiotherapy and chemoradiotherapy can definitely be tiring, so having someone to drive you to hospital can be helpful, especially towards the end of treatment. I think one of the really common side effects that people experience is fatigue. There's another type of radiotherapy that I specifically wanted to highlight this evening, which is called stereotactic ablative radiotherapy, or SABR. Also, this is called SBRT, which stands for stereotactic body radiotherapy, but it's the same thing. Sometimes also people might call it CyberKnife, and this is the brand name of the machinery that delivers the treatment. So SABR is very precise radiotherapy that delivers higher doses of radiation in a shorter time, usually 5 sessions. It delivers the radiation very precisely and from multiple angles. And this approach means that cancer cells receive a higher dose of radiotherapy, and that the surrounding tissues aren't affected, so they're spared. And this is, quite a big issue, thinking about where the pancreas is, and it's in quite an awkward spot, close to lots of different structures and organs as well. A person would have at least 3 months worth of chemotherapy before having SABR, and the SABR would start at least 2 weeks after the last dose of chemotherapy. And there isn't any chemotherapy that's given alongside SABR, like conventional radiotherapy. And a CT scan would usually be done around 6 to 8 weeks after this treatment. Each visit for SABR takes around 45 minutes. Towards the end of 2021, NHS England commissioned SABR and recommends the use of this treatment for people with locally advanced pancreatic cancer whose disease has remained stable after 3 months of chemotherapy. And we hope that this treatment will be commissioned right across the UK. There hasn't been a study directly comparing how effective SABR is to chemoradiotherapy. However, there is now more evidence supporting improved outcomes for SABR rather than chemoradiotherapy. We know that there are fewer side effects, as SABR is more precise, as I've said, so nearby organs or structures don't receive the radiotherapy inadvertently. Treatment with SABR is given over a much shorter time frame, so the impact is less for people going through this. The use of SABR as an alternative option for chemoradiotherapy means that people require fewer daily hospital visits, and they don't require that oral chemotherapy as well, so are spared the side effects of that. We're now going to have a think about and a look at a treatment called irreversible electroporation, or IRE. As I've said, it's also known as NanoKnife, which again is the brand name of the machine used to deliver the treatment. IRE is a treatment that uses electrical currents to damage and destroy cancer cells. IRE for pancreatic cancer involves inserting needles around the cancer, and electrical currents are passed between the needles, and these currents damage and destroy the cancer cells. IRE may be suitable for people with locally advanced pancreatic cancer, and it also might be offered to some people that have borderline operable pancreatic cancer, where surgery to remove the cancer may be possible. IRE may be used in that context to treat the cells around the edges of the tumour, and this is to make removing the cancer as successful as possible. IRE aims to slow the growth of pancreatic cancer, and it may help some people with locally advanced or borderline resectable or operable cancer to live longer. Before having IRE, you you would normally have 3 to 6 months of chemotherapy. It can cause side effects such as pain, feeling and being sick, and heartburn. And it can also cause other side effects as well, such as inflammation of the pancreas, which we call pancreatitis, or more rarely, a blood clot in a vein. You can see there we've got a fact sheet as well on IRA if you wanted to know a bit more about it. So what does the evidence that we have, the clinical evidence, say about IRA? We know that there hasn't been much research into IRA for people with pancreatic cancer. So sadly, that means at the moment we really don't know enough about how well it works, who is most suitable to receive it, and the side effects and complications. The National Institute for Health and Care Excellence, or NICE, has recommended that IRA should only be used in research. And at the moment, researchers are setting up a clinical trial in the UK to look at IRA for pancreatic cancer. And this is called the LAP-PI trial, which is the first UK-based trial of pancreas IRA in people with locally advanced disease. So this trial will assess feasibility and safety of delivering this treatment, and if it's successful, this trial will progress to a much bigger trial. When we know more details and when that trial, that LAP-PI trial, is open, you'll be able to find details on our trial finder. And until that is available, we know that NHS hospitals that are currently providing IRA are collecting information about how well it works. Okay, so I'm going to pass back to Lynne. Stop sharing.
Thanks, Rach. I'll start sharing my screen, hopefully. Okie dokie. So I'm bringing up the rear of tonight's session with a discussion on clinical trials and genomics. I think that clinical trials and genomics can feel quite complicated. Certainly from a nurse, it can feel quite complicated at times, but I hope that having a few minutes now and going through these slides will help to explain things a little. And I hope that tonight I'll be able to explore and explain what clinical trials are and why are they important in the treatment of pancreatic cancer. And I also think it's important to explore some of the terminology used in research, because that might help to understand sometimes what you're being told in regards to clinical trials. I'm going to explore very briefly the role of genomics and how that plays in treating pancreatic cancer. So what do we mean by a clinical trial? Well, very simply put, a clinical trial is a research project that compares 2 or more treatments in a group of people with a particular condition. And for us, that's pancreatic cancer. And what is the aim of a clinical trial is that it helps to generate high quality evidence about the treatment that it's exploring. And that's because in healthcare, everything that we do has to be evidence-based. And you'll remember from previous slides where I was talking about how research has developed drugs over the years for the treatment of pancreatic cancer in all of different settings. And that's the evidence base that is collected by clinical research. There are, of course, advantages and disadvantages of everything we do in healthcare often. And the advantage of a clinical trial is that you will get access to new drugs or new regimes or using known drugs in different ways and in novel ways. And there may be fewer side effects than standard treatment. You often are followed up closely. So in clinical trials, you often have to attend clinic more frequently. You might have more frequent bloods and more frequent scans. And a lot of people who enter a clinical trial are often thinking of other people rather than themselves, and their, you know, how their participation can often improve future cancer treatment. The disadvantages are that the new drugs and the new regimes may be no better or worse than standard treatment. And we don't know who will benefit and who will not. We don't know which drugs were going to be helpful or not. That's the purpose of clinical trials. There could be worse side effects. It could be that the clinical trial that's available to you is not available in your locality, so you may have to travel more. And the extra visits and the extra bloods can, for some people, be burdensome. And there is that uncertainty we've just discussed, which for some people is very difficult to deal with. So are clinical trials for everyone? In short, no. I would say clinical trials aren't for everyone, but I absolutely would advocate that you speak to your oncology team about what's available for yourself or your loved one. And the things that are something that your healthcare team will be looking at, each study has strict rules of who can take part and who can't take part, and that's called inclusion and exclusion criteria. And this it can involve various different things which we've listed, but often it's about age, fitness level, have you had previous treatment, and what type of cancer you have. And even if you are, you tick all the boxes, if you like, for the exclusion criteria, they still need to go on to have screening. And these can be special blood tests, special scans, heart tests, urine tests, by another biopsy. And then all of this is considered before people will go on to be recruited into a clinical trial. So exploring options is really key, and I've talked about exploring that with your team, but also it's important often to have good information about clinical trials, and we do an information leaflet. We also have a clinical trial finder, which I've put on the screen here, where you can put in some keywords and you can search, and this will search for any clinical trial within your keywords that you've put that's available in the UK, but also internationally. This can feel a little bit daunting or overwhelming. Certainly something I would say is that if you want to have a discuss about clinical trials, please pick up the phone and give us a call on the support line. I think it's important to explore here the different terminology that's sometimes used in clinical trials, and because you can get a list of clinical trials that might be appropriate, and they'll say things like phase 1, phase 2, phase 3. And clinical trials move in this system of going from phase 1 to phase 2 if it's successful to say phase 3. But what that means is often in phase 1 studies, it might be that there isn't looking at people with pancreatic cancer specifically, but more any cancer that's in a solid organ. And it might be a small group of people that's recruited, and it's just to find out how safe a drug is. Phase 2, a little bit bigger, and might be more disease specific. And phase 3, those larger groups will be disease specific. So for phase 3 pancreatic studies, it will be looking at that. And it's usually international. It's usually lots of hospitals, lots of people involved in these studies. And it's important to understand that terminology for asking questions. And so I think that asking questions of your team about clinical trials is important if you want to pursue this. So it's about what type of trial is relevant and what phase is that. Whereabouts might the trial be located? Do I need to travel? You'll be given information on a trial, and it can be pages and pages and pages of information, which will cover some of this, but also I think it's really important to know who to contact if you have any questions about the trial or trials that you've been offered. So some of the challenges of clinical trials. So we know that clinical trials can take years to complete, and sometimes even then can still not have a positive result. And what that means is that the trial didn't do what they hoped it would. And it can take years for a trial to get from planning to the drug be available to be used in practice. And also it's important to mention that just because a trial shows a positive result, it doesn't mean the drugs will be automatically available to you or to use in. And this can be due to lots of things, but sometimes it can be due to how the trial was set up. And I wanted to mention that because we have an example in pancreatic cancer that's useful to go through to demonstrate this. So you'll remember this this arrows from the chemotherapy discussion. So we talked about the key studies that have happened in palliative pancreatic cancer treatment. And the most recent one of note here is the gemcitabine with Abraxane. And, it was published that it increased survival, which is exactly what we wanted it to do. However, one of the challenges of interpreting what happened in the study is that it wasn't compared with the gold standard of treatment. Which was the FOLFIRINOX. You'll remember it was compared with gemcitabine. So when that drug and when that result, the Gemabraxane, was put to NICE for use for people with for palliative pancreatic cancer treatment, there was some discussions and some restrictions placed on how it is used. So thinking about the license, Gemabraxane is only able to be used for people with a metastatic pancreatic cancer in first-line treatment. And so those considerations are, we know FOLFIRINOX can give people a better outcome, but gemcitabine and Abraxane is not licensed for second-line use, which is confusing. And definitely something to discuss with your team should you be having discussions about Gemabraxane and FOLFIRINOX. I don't want to confuse things, but I just wanted to demonstrate that sometimes even good research and positive outcome research sometimes doesn't translate into practice. So my take-home messages on clinical trials is trials aren't for everyone, but it's certainly, again, I advocate you discussing this with your team. You can ring us on the support line and discuss that. It's strict rules for who can take part and who can't. You'll be given lots of information. Different phases of trials can it's good to understand them, because it might be that certain studies that you're offered might be better than others. And that's something to discuss with your trials team or us on the support line, of course. And, one of the big issues with trials for people often is you don't know if the drugs being used are going to be helpful or not, and that uncertainty can sometimes be difficult for people to deal with, understandably. Genomics in pancreatic cancer. So genomics can feel a little bit overwhelming, and it's a term that we are using quite genomics quite a lot in healthcare. But what does that really mean? What does that really mean for pancreatic cancer? So I thought I would just explore that a little bit, if that was all right. I really like this definition of the genome because it made sense to me. So I hope it makes sense to you. And so the genome basically is the whole book, if you like, of information that cells have. So inside every cell is the genome. The genome tells the cell what it is. So it'll say you're a pancreatic cell, you're a liver cell, and this is how you function. And as we discussed before, when a cell divides, that genome is copied perfectly into the two sister cells that come off. However, sometimes when those cells divide, mistakes happen in the genome, and that's what we call mutations. So genomic profiling is something that has come more to light in the understanding of cancers and the development of treatments over the last 10 years or so, probably more. And that's because understanding any mutations that might be present for people with cancer can improve the way they're diagnosed, improve the way they are treated, and improve their options in regards to clinical trials. However, it's really important to know that genomic screening is not a treatment in itself. It's a gateway to possible treatments. Within pancreatic cancer, only a small percentage of people will have a mutation. And even if a mutation is identified, because the genome is becoming more and more understood as time goes by, so those mutations are being explored and discovered, but not every mutation has a clinical, has treatment available or a clinical trial that is open. So people often get a little confused, me too, about the mutations. So inherited mutations are something we call germline mutations. And so that's something that we inherit from our parents. And one such mutation that is of interest in pancreatic cancer is BRCA, which we'll come to in just a second. But every cell in someone's body will have the mutation in it. And somatic mutations, these are mutations that only are in the cancer. So what that means is that the cancer itself will have a genetic mutation in it that is not seen on the rest of the body's cells. So when we have genomic profiling or screening done from cancer, for someone with cancer, it will be taken from their biopsy. So good biopsy is key, but they will also take blood to sort of cross-reference, if you like, for germline mutations too. So what are your options for getting genomic screening? Again, I would advocate that this is a discussion to have with your oncology team. There are some genomic services within the NHS. They are restricted. And this is something to discuss with your team, is what are the options locally for you. Most pancreatic cancer screening happens as part of a clinical trial. And so it is screened for a certain genomic mutation, or screened for genomic mutations that's related to whatever drug is being developed or being used in the clinical trial. There are private companies who offer genomic screening, and genomic but PARP is a protein that's found in all of our cells, and it helps repair damaged cells. PARP inhibitors are a type of targeted cancer treatment. The treatment, what the PARP inhibitor does is stop that repair in the cancer cells, and with that, the cancer cell dies. So why is that important in BRCA? So when they first started, I say we, it wasn't me, but when they first started looking at PARP inhibitor drugs in cancers, they wanted to focus on cells that already had problems in repairing themselves. And they focused on a cancer with a fault in the gene called BRCA. And you may have heard of BRCA in other things like breast cancer, prostate cancer, And so yeah, so BRCA1 and BRCA2 are genes that we all have that play a part in our repairing cells in our body. So when there is a fault in those genes, they are less likely to repair themselves. So people who have a faulty BRCA gene have an increased risk of certain cancers, which includes pancreas. So the cancer cells with a BRCA gene already aren't able to repair themselves very well. So when we block PARP with the PARP inhibitor, that mutated cell with that BRCA fault is unable to repair itself, and then it dies. And so that's how using targeted treatment for certain gene faults can really can help treat cancers. And, you know, like I say, this is targeted treatment that has been used in pancreatic cancer research. So one of the drugs that is a PARP inhibitor is olaparib. And so this was used and explored in treating metastatic pancreatic cancer with the BRCA mutation. And this was found to have some benefit, but also found that people with a BRCA mutation benefited better from having first-line gemcitabine with a platinum, in this case, cisplatin. So these are different types of chemo. You'll remember from the chemo talk, we talked about how different drugs do different things, and we use in combination. So this is a combination that has started being used for those people who have a BRCA mutation first line. But again, olaparib is something that NICE has not approved for general use for people with the BRCA mutation. However, you can access this drug via a compassionate grounds through the drug company. If you want to know more information about this, pick up the phone, come and speak to us on the support line, and we'll be able to share that details if it's relevant for you. So I also wanted to put a quick slide in, and I realise I'm going over my time dramatically, but vaccines for pancreatic cancer, there's a big buzz around vaccines, and this is due to lots of reports in the media about a pancreatic cancer vaccine. This is being pioneered through the team and the science that was discovered through developing the COVID vaccine. However, the news is somewhat skewed. You know, the news is very positive and it is something to be excited about, but the news is referred to a small group of people in a very small trial, only 16 people. It was only tested for those people who'd had surgery, so adjuvantly after surgery trial. 50% experienced a good response. And all 16 of the people in this small study had chemotherapy and another targeted drug alongside this vaccine. So yes, the headlines are right. It's an exciting time, but you know what this has led to is a smaller study has led to a larger phase 2 study being planned, and the numbers are going to be bigger. So like what we discussed in the research thing, they're going to be bigger, I hope, but still only available to those having surgery. But bigger numbers means we get a better understanding. And what I hope from that, if it's positive, that will lead to clinical trials in vaccines for all people with pancreatic cancer. So take-home message, understanding your cancer genome can open up treatment options, but remember mutations are rare. I encourage, again, that you discuss with your team, your oncology team, the options regarding genomics. And often genomics is part of a clinical trial. And mutations can be identified, but no treatment sometimes treatment is not available. So yes, so they're my take-home messages. I hope that all made sense, or made some sense. Please put your questions in the Q&A box, and we are heading to the Q&A now.
Great, thanks, Lynn.
No worries.
Well, so yeah, we've got a few questions. Maybe I'll start off with some of them and give you a little chance just to, you know, get your breath back, and then there are a few questions on a similar vein, or yeah, so hopefully we can group some of them together. So there is a question I'll start off with from somebody that's asked, are there any dietary and vitamin recommendations to slow cancer spread or kill cancer along with the chemotherapy? Yeah, I'll answer this one. So sadly, no, there aren't any dietary things you can eat, any vitamins that you can take that will slow down the cancer spread. We know, however, that good nutrition and particularly pancreatic enzymes, which I'm sure a lot of you will be well aware of and be taking, are so important within pancreatic cancer, given the common difficulties that people will face that have pancreatic cancer in terms of their digestion and the role that the pancreas usually plays in effective digestion. So no, there isn't any specific thing that you can take or eat that will slow cancer spread, but we know that effective nutrition is incredibly important because studies have shown that stabilizing weight loss and effective nutrition will allow somebody to get through all of the chemotherapy sessions that are planned and hence give maximum opportunity for that chemotherapy to be as effective as it can. Hopefully that answers that question. I don't know if you would add anything to that, Lynn. Or...
I don't think so. I think that was a great answer. Yeah.
Well, glad you agree. Okay. So somebody has asked, so I'm just looking through them. Somebody's asked nab-paclitaxel, or so the name Abraxane and gemcitabine, is a combination that can be used, ? My father has been diagnosed with metastatic pancreatic cancer. So yes, as Lynne's mentioned, nab-paclitaxel and gemcitabine, or gemcitabine and Abraxane, which is often called, can be used to treat metastatic pancreatic cancer. So here in the UK, it's used as first-line treatment for metastatic pancreatic cancer, particularly if somebody wasn't as fit as when we talked about performance status and things. Sometimes people that have not fully active or are a little bit down on the performance status because of the side effects that can occur with FOLFIRINOX, gemcitabine and Abraxane may be a really good option for them. So yes, it is a combination that's used here in the UK. Okay, so I've done that one. Sorry, I'm just looking. I'm going a bit dizzy. Someone's asked, does a course of a particular chemo drug have to be followed, or can changes be made? So again, I'll answer that one, and then so usually somebody would have a chemotherapy drug or a chemotherapy combination for a planned number of cycles. And Lynne explained that usually somebody would have a certain number of cycles depending on what that chemotherapy is, and then after 3 months of treatment would have a CT scan to assess response. However, if in that period of time somebody was really struggling with the side effects or toxicity of the chemotherapy, then, as Lynne said, tweaks would be made, can be made to the chemotherapy combination, sometimes in the dose, or sometimes even, if it's something that somebody's really struggling with, then it may be appropriate to omit one of the drugs in the combination. So changes can be made in that sense. But usually it would be a scan after 3 months to assess response. If at that stage somebody's cancer was not responding well to that chemotherapy, or if their disease had progressed in that time, then discussions would be had possibly about a second-line chemotherapy, if that was appropriate. Also taking into consideration how somebody tolerated the treatment and what their wishes were. Okay, so we've got some that are around genomics and things. So maybe if I group some of those together. So somebody's asked, is the BRCA mutation something that you would discover in genomic or germline testing? Do you want to answer that one, Lynn?
So yes, so BRCA mutation is something that would be picked up when you have genomic profiling. Yeah, and that's the only way of picking genomic mutations up would be within genomic profiling. And so, yeah, so that would be picked up in germline, so inherited mutations that you inherit from your parents, but also can be picked up when a biopsy is screened and genomic profiling. Remember, usually they would be cross-referenced too. I'm not sure if I answered it.
Great. And then someone's also asked, I would like to ask what specific testing needs to be done to determine if someone is a candidate for immunotherapy and targeted therapy?
So very much the same answer. So the things that influence targeted treatment are any genomic mutations, and targeted treatment means that it's targeting that one thing. That PARP inhibitor is a targeted treatment because it targets the PARP, which I know probably sounds really logical now I've said it. But yeah, so genomic profiling explores that. And so immunotherapy, vaccines, targeted treatment, things like that, these new novel therapies that are coming through, absolutely, it's about mutations in the genome.
Okay.
I feel like I said genome a lot tonight.
So another question, I'm not entirely sure exactly what it means, but we'll give it a go. Someone's asking, I've seen others talk about PNC27 peptides and nanoknife procedures. Are these things we should be asking about? Sorry,
go on.
No, you say what you want to say.
Is this a radionuclide peptide, I wonder?
It could be, yeah. I guess it must be if we're I guess I don't know anything about that personally just now, but I'm certainly happy to have a little look at that, and then maybe we could contact you outside of the webinar perhaps.
So I had a recent inquiry, about targeted radionuclide therapy, which are peptides, and if this question is about that, there is not a lot of evidence out there of these types of treatment being used in pancreatic cancer. However, I believe that there is a trial coming up, but I don't know where it is in setup for these peptides, radionuclide therapy. Not sure if that's what you're asking, so I might have confused people even more, so apologies, but absolutely we can find out for you and get back to you if that's helpful. Yeah,
we certainly can. I guess with the nanoknife I can certainly answer that bit. So with nanoknife, as we've discussed and highlighted this evening, we're still really lacking that evidence to back up the clinical efficacy of nanoknife and other things around it as well, such as complications. So nanoknife is certainly something that you can ask about. As I say, it is on occasion being offered to people with locally advanced pancreatic cancer and borderline operable pancreatic cancer. So depending on your situation, that might be something to consider. So usually it would definitely be a case of a multidisciplinary team reviewing imaging and all of a person's medical information to see if that was something that they could possibly be you could possibly be eligible for. Again, you know, if you wanted to give us a call on the support line, we can go through that in a bit more specific, with in specific ways with you. Someone's asked, what does locally advanced mean? So certainly, yeah. So locally advanced means pancreatic cancer that is,
sorry,
is in the pancreas, but has grown outside of the pancreas locally, usually spread to major arteries and major veins that are very nearby, and possibly other structures as well, including lymph nodes that are nearby to the pancreas. So it's pancreatic cancer that hasn't spread to distant organs in the body. So yes, so usually locally advanced pancreatic cancer is categorized as stage 3 pancreatic cancer. Hopefully that answers that one. Somebody's asked, is it common that having chemotherapy can sometimes extend life for only a month or 2 at the most?
So shall I answer?
Yeah, go for it.
So common is a difficult word, isn't it? Because, you know, what you'll remember from my talk, that we just don't know with chemotherapy who will benefit and who will not benefit. And unfortunately, we do have people who have chemotherapy and the benefit can be very slim. But we also, the flip side of that, have people who are on chemotherapy and they have a fantastic response. But, you know, it's very difficult to say, but you are right. It's, you know, there are those cases where chemotherapy doesn't work at all and is of no benefit. And that's very difficult. And that's when we have to think about the other bits, which Rachel covered right at the beginning about, you know, the benefits and the burdens of everything. And that's why we have this follow-up in clinics, so that they can assess for that. But yeah, it is challenging with pancreatic cancer. Chemotherapy can offer, like I say, great things for some people and less great things for other, and there's just no way of telling, which is why targeted therapies offer another avenue, because chemotherapy isn't a targeted personalized treatment. It's a broad treatment for people with pancreatic cancer, but what we know is that that's our best option at the minute. I hope I answered that okay.
Brilliant, thanks. And then somebody's asked, is SABR, so the stereotactic ablative radiotherapy, is that a possible treatment for stage 4 pancreatic cancer? So sadly, SABR wouldn't usually be offered to people that had stage 4 pancreatic cancer, which is distant spread of disease, or sometimes also called metastatic pancreatic cancer. As we've explained, SABR is a type of radiotherapy which is a localized or targeted treatment. So unfortunately, SABR is not an appropriate or effective treatment for metastatic or stage 4 pancreatic cancer. Somebody's asked, I have chemotherapy followed by the white blood cell injection. The chemo seems okay, but the injections cause significant bone pain for a day or 2. Any pain relief advice?
Yep.
One to you, Lynne.
So quite common, these injections are used, and they may be called filgrastim or GCSF, and they're given after chemotherapy often, and FOLFIRINOX, and they are help to mobilize your bone marrow in producing white cells. Basically, they don't introduce white cells, but they mobilize. But with that comes bone pain, which you've had. Usually in the big bones, so it could be the pelvis, could be the femur, etc. So it's quite common that people will need pain relief, and that can depend on what you're already taking. So simple paracetamol can help, but it might be that you have things in your arsenal regarding pain relief that you take regularly anyway, or something you have for something we call breakthrough pain or PRN pain. So something you take as and when. For me, prevention is better than cure for all side effects of chemotherapy, and I would class that bone pain following the injections as a side effect of your treatment. So if you notice that when you have your injection on day 3 or whatever it is, and you notice day 3, 4, 5 and 6 you have increased pain, take something to prevent that. And that would be my advice for anything. So if you are noticing you've got nausea on day 5, 6, 7, 8, whatever, I would advise taking anti-sickness on those days to prevent that rather than cure it, which is why I always recommend in my top tips keeping a small diary, like a quick diary, because then you can pick up what days you struggle with what side effects and how you might go about treating that to prevent rather than cure, keeping you feeling better. There's another question that's come up about, can the white blood cells cause loose stools? I'd pass is my honest answer to that. I don't think so, but I would say potentially the loose stools, if on that, could be related to the chemotherapy. Thing to be mindful of is also you can get diarrhea due to poor enzymes. So you've got quite a lot going on in the bowel department when you're on chemotherapy for pancreatic cancer. And like I say, so the irinotecan and the oxaliplatin, the fulferinox can cause diarrhea. So if you notice a pattern coming, you might think about preventing that. And you can, and there's different, you can get in touch with us if you want some advice that. You also, your hotline, a chemo hotline, or your nurse specialist.
Great. Thanks, Lynn. So we don't have any more questions coming on. I'm just aware that that person that asked about the peptides, I wonder whether they would be happy to send us an email on our support line.
I think she said she was going to give us a call.
Okay, great. Brilliant. I just didn't want to miss that. So I'll pass to you, Lynn.
Thanks, Rach. And so that concludes tonight's webinar. We've covered quite a lot of stuff, and it might be that you have questions from what we've discussed that come overnight, hopefully not in your sleep, but you can pick up the phone or drop speak to us on the support line or drop us an email. But I just wanted to take this opportunity to thank you for joining us tonight. I also want to thank Jenny and Nadia, who are in the background. They are the backroom people who have been fantastically managing chat and our admin and keeping us on the straight and narrow. So thanks to Jenny and Nadia. Also thanks to Rachel for her contribution this evening. But yes, so just thanks again. Please fill out the feedback forms. The slides are available hopefully in the next few days on our website. You can watch this back, and wishing you all a good night. Good night.